Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope. Now, we have a really interesting case, but it's also kind of a sad case, and that will become more apparent during the course of the video. So if I give you a summary and then I'll revert back to the video and explain a bit more about the condition this patient has, but you'll see I've just removed that block of hardened keratin, and beyond that this ear is full of otorrhea, so discharge, and it's very thick purulent discharge, really thick and dense, coating the entire ear canal and also the eardrum. There may also be some fungal spores there. You can see at the bottom there's some black spores, and whilst you continue to watch me just clear this up, I will jump back to the video at certain points. So this patient initially visited me back in February 2022, and during the procedure I was concerned that this patient may have a rare external auditory canal cholesteotoma, which will become visible in a moment to you. So I wrote immediately to their GP. They also were suffering from tinnitus in this ear, so it's when it's in one ear unilateral, or if it's asymmetrical, so worse in one ear, or if it's pulsatile in nature, that immediately warrants an ENT referral. If there's no other obvious cause, if there's earwax and we clean the earwax, or they've got a middle ear infection, for example. So even after I cleared their ear, they still had tinnitus. So this is going back February 2022. And with a rare canal cholesteotoma, typically that's a priority referral to ENT. This patient then came back to me, because after we write to the patient's GP, we also send a copy to the patient of the letter that we sent. And in a way, that's where our involvement ends, because I'm a private audiologist in the UK, and the NHS is a different entity. So we, after seeing patients, if they need further medical attention, it's our duty to write to the GP, and I also make sure I send the patient a copy of the letter just in case as well. Now, this patient then came back around 18 months later in November 2023, and so I was reviewing the notes, and I asked the patient if they've been seen by ENT, and they advised that they hadn't. So I cleared the patient's ear again, and once more I still had the same concerns that this patient had a external auditory canal cholesteotoma in the left ear, and in addition, in their right ear there was a really small ulceration. So when we say ulceration, the skin was missing, so some of the underlying bone was exposed, but not. It was minimal at that stage. So I wrote back to the GP again in November 2023, and I requested an urgent referral again, because it's been 18 months since this patient first saw myself, and I had some concerns. Now I understand that the NHS is literally on its knees at the moment, and the waiting lists are huge. But with conditions like this, they're typically urgent referrals, and it's what we also requested. And not everyone, unfortunately, is able to afford to see an ENT privately. So again, we sent a copy of the letter to the patient. Now, this patient just attended again yesterday, and again, the first thing I asked was, have they been seen by ENT yet? And when they attended yesterday, I just couldn't hear a thing, so I couldn't have a conversation until I cleaned their ears out. And after I cleaned their ears out, they advised no. So whilst the patient was here, we just had to act upon this immediately. So we rang the patient's GP and the surgery, who, upon obviously the request and consent from the patient, who advised that the surgery advised that they did get the referral that I sent last year, and they did ask for an urgent referral, but obviously the patient, for one reason or another, hasn't received that. So the patient's quite elderly, and they asked that I call their son just to explain what's going on, because the son will be better able to understand. And so I spoke to the son, and I said, look, it's been 2.5 years now since I first raised concerns about this left ear. Are you able to, although I'm going to write to the GP for the third time, are you in a position to see an ENT privately? And they said yes. And so we provided some details, and this morning they advised that they've already booked in. So what you're seeing here on the left hand side, this is exposed bone. So this patient's external auditory canal cholesteotoma is localized on the anterior osseous portion of the ear canal. So cholesteotoma typically forms on the bony portion of the ear canal, so the osseous region. And the inner 2/3 of the ear canal is composed of bone, whereas the outer third is composed of a cartilage. And this bone, so the skin lining the bone has ulcerated, so it's no longer present. Just to the right, the skin's quite inflamed. And what I'm trying to do is clear out any pus that's stemming from this region. There is some granulation tissue there also. And when you touch this, the bone, it's rock solid. The suction probe literally glides off it. So on the left-hand side of the ear canal, there's a huge portion of the bone missing now because this bone has become necrotic. It's kind of basically decaying away, and some of the bone has separated. And there are some other conditions that a canal cholesteotoma can become confused with. One of those is keratosis obturans. With a keratosis obturans, that's a dead skin plug, but the skin is not ulcerated. You get a global widening of the ear canal, and a hallmark symptom of a keratosis obturans is otalgia, ear pain. This patient didn't have any pain. They didn't report any discharge because all the discharge was collecting behind that initial plug of hardened keratin that I removed. When I removed that, there was a strong foul odour coming from the ear, so even before I went back in with the endoscope, I knew there was an infection there. There's another condition called a malignant otitis externa. That's where the bone surrounding the ear canal, the temporal bone, becomes infected. So it's a form of osteomyelitis, and it can become secondary to chronic otitis externa. There are other causes there. With malignant otitis externa, the hallmark symptoms are nocturnal otalgia, so pain at night, really severe pain. And you get a massive buildup of granulation tissue from the floor of the ear canal, which will kind of semi-occlude, if not fully occlude, the ear canal itself. Now, you can't really rule that out, but this to me seems like more like a canal cholesteotoma. There's more evidence of that in their right ear because they've also developed, I feel, external auditory canal cholesteotoma in their right ear, which you'll see after this procedure. Another condition is a benign osteonecrosis. That's when the bone at the floor of the ear canal, on the osseous portion, it's starved of the necessary blood supply that it requires for the bone to keep rejuvenating itself, because bone in the body keeps rejuvenating itself. It's continuously recycling its own tissues and minerals to form new bone to keep it healthy. But when you've got reduced blood flow to the ear canal and typically to the floor of the temporal bone, the bone dies and it starts to separate. But more often than not, with a benign osteonecrosis, you don't get ulceration. The skin is still present. Here, the entire skin is just missing, and even further down in the ear canal, the skin, I was beginning to peel it and I realised that skin is not dead skin. It was actually skin that's inflamed, and there's also an erosion underneath that. So I cleared the pus out. You can see so all that yellow stuff there, that is bone, that's exposed bone, and the suction probe is gliding off it. But what we're trying to do here is just clear any pus. It's very difficult because this pus is very, as I said, very thick. So when I start clearing, because I want to clear as much as possible, because we don't know if there's other erosions and possible canal cholesteotomas within this ear canal. I've had cases in the past where there's multiple lesions in the ear. So it's really difficult to suction this because it just didn't want to come away. And you'll see that when I start suctioning some of the back part of the ear canal, I'm over the discharge, but it's just not vacuuming because it's so thick. We still got to clear the eardrum. So I've partially cleared the eardrum. But obviously we want to make sure this patient... So my main priority is obviously on the right, so when you're watching it on the left-hand side of the ear canal, but we also want to make sure this patient can hear. That's the main reason why they came today, or yesterday, should I say. So I'm going to go back to the eardrum. So what's an external auditory canal cholesteotoma? It's a localized skin cyst. The skin cyst, it's not unlike a keratosis obturans where the skin is dead. some of the skin involved in an external auditory canal, it's still metabolically active, so it's self-growing. So that epidermis layer of skin that lines the inner 2/3 of the ear canal and the eardrum, the epidermis layer itself has got 4 layers. With the keratosis obtrans, it's only the superficial layer, the stratum corneum, that's involved. And that stratum corneum, the skin is dead and it forms into a plug. With the skin cyst that forms the external auditory canal cholesteotoma, all 4 layers are involved, including the basal layer, so the stratum basal. And it's at the stratum basal layer, which is the innermost layer of the epidermis. The skin cells there are metabolically active and they actually undergo mitosis, so they reproduce new skin cells in that basal layer. And with the skin cyst, it kind of almost curls into a ball. So the outer layer is the basal layer, the inner layer is the stratum corneum. So on the outer layer, that's where you're getting all this new formation of new skin, and in the inner layer you're getting an accumulation of keratin, because keratin is the protein found on the outermost superficial layer of the epidermis. But that's been the way the skin cyst forms, that kind of collects within the cyst itself in the center. And because this skin cyst is metabolically active, it's releasing what we call proteolytic enzymes. And these enzymes cause local destruction to the skin, to the bone. If there's any nerves there, it just basically chews away at it. And then you have bacterial involvement, or possibly even fungal involvement. And with the bacteria, it also itself releases these proteolytic lysosomal enzymes. So with a canal cholesteotoma, it's very localized, unlike a keratosis obtrans. The normal site of a canal cholesteotoma is on the inferior canal wall, but it can also occur posteriorly on the back part or on the anterior canal wall, which is what's happened in this patient. Now, the incidence rate of an external auditory canal cholesteotoma, I'm a bit dubious about, because the literature states it's 1 in 1,000 patients who visit either ENT or an audiology practice. So it's not 1 in 1,000 of the population, but 1 in 1,000 of people who attend an ENT or audiology appointment. And I'm seeing quite a few. So the incidence rate of what I'm seeing is far exceeds that. I'm probably getting one every, and I had a couple last month, so I would say 1 every 2 months. It may even be more, but roughly I'm seeing kind of, 1 every 2 months. And I don't see 1,000 patients I'd love to, but I don't see 1,000 patients every 2 months. I don't think there'd be any hours in the day there. So now, is that because possibly external auditory canal is going undetected? Because sometimes it lurks under blankets of epithelial skin, dead skin. So you need to remove that before it's visible. So, and as I said, some patients don't experience any symptoms. There may be some discharge there may be some itchiness and irritation, but they can be non-symptomatic. Now, the causation, the pathogenesis or etiology of external auditory canal cholesteotoma makes it more susceptible in elderly patients, and I'll kind of explain that in a bit more detail. So as mentioned, the clinical symptoms, there can be none. Otherwise, it's kind of a slow, progressive, dull ear pain and discharge, so otorrhea. And typically it's unilateral, so in one ear, but in this case, it would appear that it's in both ears. And when the ear is completely occluded with pus and dead skin, it can lead to what we call a conductive hearing loss. So the organ of hearing itself is unaffected, but the sound can't travel through the ear canal to vibrate against the eardrum. And when the sound vibrates against the eardrum, there's 3 bones, ossicles, connected to the eardrum, which then transmit the sound waves to the cochlea, the organ of hearing, where it then stimulates hair cells that produce an electric signal, which is then sent to the brain via the auditory nerve, the 8th cranial nerve, where we then perceive it as sound. So again, one of the hallmarks of an external auditory canal cholesteotoma is an ulceration. So the skin that lines the ear canal is ulcerated, so it's kind of diseased, decayed away, which then exposes the underlying bone. And it's the bone that decays, so we call that osteonecrosis. It's very focal. It's normally at specific parts of the ear canal. It's not global all the way around. And you kind of get 4 stages of an external auditory canal cholesteotoma. So stage 1 is when the epithelial skin in the ear canal, there's a build-up. So we call that hyperplasia, the build-up of epithelial skin. And it's underneath that sometimes where you need to be able to remove that to kind of see what's lurking underneath. Stage 2 is when the periosteum, which is a thin kind of sheath membrane, if you like, that sits on the bone, which supplies the bone with all the blood, nutrients that it needs to maintain life and kind of rejuvenate itself. That periosteum becomes infected, so it's called that periosteitis. Stage 3 is when you get erosion, so osteonecrosis of the osseous portion of the ear canal. And so on here, the patient's bone is becoming eroded, and quite significantly so. So I'll come back to that in a moment. So what you're seeing here is the eardrum, and I'm just trying to suction all this pus, this thick purulent discharge, off the eardrum. So this is probably the southern hemisphere, if you like, the pars tensa. And where I am now, that's where the umbo is. That's where the hammer bone attaches to the middle of the eardrum. So I'm just trying to clear it because, and I'll come back to this a bit later if I have time, which I should have because it's another 16 minutes to go. But this patient has also recently been diagnosed with bilateral nasal polyps, which may block her eustachian tube. And when the eustachian tube is blocked, it could cause a retraction of the eardrum. And you never know, the patient may also have, this pus may be originating from what we call a middle ear cholesteotoma as well. So this is that skin I referred to a bit earlier on. So I thought the skin was ready to be peeled, but it's not. The skin is skin that's actually still kind of alive, if you like. It's not dead skin. And you can see it's pus and start underneath that, so that's also ulcerated. So we just kind of cleared out some of the pus there, and there's some granulation tissue there. So so stage 3 is when you get an erosion of the bone. Stage 4 is when the erosion really advances and it invades adjacent structures to the ear. So if the external auditory canal cholesteotoma is localized posteriorly, it can invade the mastoid region. So the mastoid bone is the bone directly behind your ear canal. So if you place your finger behind the satellite dish of the external part of your ear, there's a flat portion there. That's the mastoid bone. It's air-filled and it's got a honeycomb structure. So an external auditory canal cholesteotoma can erode into the mastoid bone, and we call that an automastoidectomy. Sometimes, but rarely, it can, depending upon the location, if it's a bit deeper, it can go inwards towards the middle ear, but typically that's not always the case. Here it's growing anteriorly to the front part of the ear canal, and anteriorly that's where your temporomandibular joint is, so your jaw joint. You've also got the parotid gland, which is commonly more on the front part of the ear canal, but a little bit lower. And in rare cases, it can cause a dehiscence of the facial nerve. So the facial nerve runs posteriorly, where we are here on the back part of the ear canal. So again, it depends on the location of this. So the bone erodes, and sometimes the bone can separate. We call that sequestrium, when the bone actually separates. There was a case that I did a few months ago where the patient had a canal cholesteatoma hidden again by hyperplasia of dead epithelial skin. So if I didn't remove that, it kind of revealed a second ear canal. It was growing into the patient's mastoid bone, and there was sequestrium of the bone. The bone had not only diseased, necrosed, but it began to separate, and I was actually removing some dead bone from there. Now, what's the causes of an external auditory canal cholesteatoma? So it can include local trauma to the ear canal, which then causes inflammation. And I'll talk about that a bit more as well. But a loss of epithelial migration. So this skin, the outer layer of skin, it should continuously be shedding itself and migrating from the eardrum to the entrance of the ear canal. So it's a conveyor belt. And we call that epithelial migration. So if that migration for whatever reason is halted or obstructed, it can lead to a skin cyst of epithelial tissue developing in the patient's ear canal. So sometimes we just don't know why patients get it, so we call that a primary external auditory canal cholesteatoma. So they're more rare and the cause is unknown, so we call it idiopathic. Then you get a secondary external auditory canal cholesteatoma. They're the more common ones, and it can happen sometimes post-operatively. Anything that causes inflammation in the ear canals, even if you're poking in your ear with a cotton bud or a hairpin, or I've had people own up to using a screwdriver even, or if there's an obstruction, so a narrowing of the ear canal, so stenosis, or even earwax. If earwax has not been removed, it can stop the natural migration of skin. And sometimes even radiotherapy, because radiotherapy, if it enters the ear in any way, it's localized to the ear, it can kill the local blood vessels. And when you've got less blood vessels in the ear canal, there's no blood flow, and it's the blood flow in the ear canal that helps to fuel this epithelial migration. Without the blood flow, the ear canal, the skin can't migrate. And so they're kind of the two causes. There's a third potential cause, and it's called an acquired external auditory canal cholesteatoma, and that's associated with congenital atresia of the ear canal. So that's when the ear canal is basically shut. There is no ear canal visibly from the external part. So with microtia, that's when the pinna, so the outer part of the ear, the satellite disc, is kind of deformed, it's not fully formed. And atresia is when the ear canal itself is closed up, and you could have a complete absence of the pinna. So if the ear canal entrance is closed up, obviously sound can't get in, but skin can't migrate, so that can also cause an issue. So again, we're just looking at this diseased bone. I see the eardrum, there's no middle ear cholesteatoma, so I did clear up all the eardrum, especially in the posterior superior quadrant. That's where the eardrum is more fallible to getting retracted, and when the eardrum gets retracted, you can get the same skin cyst that I've just described forming in the pocket where the eardrum is retracted. But I'm happy with that. That's clean. So in terms of treatments for an external auditory canal cholesteatoma, surgery to remove the cholesteatoma and all the necrotic bones, all the diseased bone. So typically then a muscle graft, and can be placed where the diseased bone has been removed to cover that exposed area. And sometimes a patient can undergo a radical mastoidectomy. So if it's growing posteriorly towards the mastoid bone, and the mastoid bone is also diseased, the whole bone is removed, the mastoid bone and the back part of the ear canal, so it creates a huge cavity in the ear canal. So this is the patient's right ear. So again, this looks like earwax, but it probably is a little bit of earwax, but it's just mainly dead skin. This ear was really, really narrow at the entrance, so it's difficult getting access. You can see it's a bit damp and wet in there already. This is a bit dry, a bit deeper, it's a bit damp. So again, it's telling me there may possibly be some discharge here. So again, I'm just trying to clear this from the entrance. I used the ear hook and I got into the plug, but it's too crumbly, it just crumbled through. Used the correct, and again it was just a bit soft laterally, so it was just smothering it wasn't removing it. So now I did put a bit of just a squirt of oil, not too much, just to kind of change the surface consistency of this, because it was very difficult to remove, and obviously cleaned it all out afterwards. But it was just enough to kind of change the consistency of this more lateral. Now, at this stage, we weren't aware there was a bit of an ulceration last time, really, really small, but there was no sign of there's no discharge. And so, again, with an external auditory canal cholesteatoma, it's infected, so there will be some discharge. So previously, there's no discharge there. So this plug came away, and then you're going to see the ear full of discharge, and you're going to see that stage 1 where you're going to get a buildup of epithelial skin tissue, So that hyperplasia of epithelial skin on the canal. So we're going to remove that, and then you're going to see some periosteoitis, so some inflammation of the underneath that, and then you're going to see some bony canal erosion. So you're going to see up to stage 3. I mean, it could be that the left side is stage 3 going to stage 4 now, because it is the bone is really getting eroded anteriorly. So beyond that fleshy part on the right hand side there, that's the second bend, and normally it's quite prominent, but in the patient's left ear, that was just all missing really. It was just a much widened ear canal. So this is that hyperplasia of epithelial skin at the bottom of the ear canal. So there's squams of dead skin here, and it's wet, so we kind of know there's something going on here, but it's still not visible. We don't know exactly what's going on, but there I'm seeing some skin. So we need to just mop up around this area. And this skin is slightly inflamed, it's raised. There's some keratin buildup inside. You can just see to the right of the sucker, which we're going to clear in a moment. So I'm going to come back to that, but I just want to clear this entrance because it's really wet. So all that pus is extruding from that region. So again, we're just past the first bend to the left. And we've got some more thickened hyperplasia of epithelial skin here. And see the skin there's edema, the swelling, it's inflamed. And I already know it's ulcerated because you can see there's where the sucker is now. There's an opening there and there's a bit of pus there. So we don't know the extent of how much this is spread in the bone. So this patient will most likely need a CT scan. So hopefully I'll have an update next week, because I think they saw the consultant this morning. So I'm just using the fine and suction. I'm going to enter this area and just suck out any pus, and that's the exposed bone now. And it's rock solid. There's a bit of pus just beyond that, so I'm just trying to clear all the pus away. And I'm just, again, clearing posteriorly, just to make sure there's nothing here. Now, you're going to see, this was a bit tricky this year because, I mean, by this stage, the patient was sat on the chair for about 45 minutes. It took half an hour with their left side. And they were obviously very tired. They were an elderly patient, and the head was, even when I was doing the left ear, the head was, although they had a headrest, it was kind of just moving towards their right shoulder. Now I'm doing the right ear, which is okay in that sense, because if I'm in the left ear and the head's moving in the opposite direction, it's less likely to come towards my instrumentation. Here, however, the head's coming towards me quite a lot, bless her, and she did find it a bit difficult to keep her head still. So as I'm going in, I'm just prepared to come straight back out, just in case this patient's head moves suddenly. So I'm just moving a bit more tentatively, and you may be able to tell that just with the movement of the suction probe. So kind of almost immediately ready to come away with the suction probe if the patient's head does drift too much or suddenly. But I just want to clear this pus off the eardrum so they can hear better. And it's good that the patient's able to see ENT immediately, because otherwise, if we don't want any delay now, I mean, it's been a long delay already. But the longer they leave this, the discharge is going to collect again, and they're going to have to have their ears cleaned once more before any diagnosis can be made by ENT. So in terms of the scenario about making a referral, I mean, just trying to think if anything more we can do now. It's just not physically possible for us to kind of follow up every letter. We send a letter, we send a copy of the letter to the patient as well, and I mean the GPs, they did acknowledge receipt of the letter as well when we contacted them, but if it's just not practical for us to call every single referral that we do just to make sure, and getting through to the GPs is very, very difficult, even for patients who need the appointment. So just trying to think of something else, anything else. You can see that erosion there, the ulceration, the exposed bone. And that's why we also, we do tell patients as well, that's why we always send a copy of the letter. So if you don't hear from the GP, do contact them, and you've got a copy, and we that's something that we always advise our patients. Now, it's quite easy for a patient once they're treated, because once I've cleaned this patient's ear, they don't suffer any pain. There's no pain for this patient. They're going to go back to normality, being able to hear again, because I've cleaned the ear canal. They can hear because the eardrum's fully cleared. So it's quite, it can happen that you kind of forget, patients just carry on. So yeah, it's kind of sad in that case. Again, we're just going to suction this here. You can see I'm just being very tentative. I'm just, any moment, I'm just waiting to come away. So we're going to just clean up the entrance a little bit for the patient. So that's the first bend, that part here with all those hairs are protruding to the right. You can see the right hand side of the ear canal. That's the second bend. Just got some crusted skin here. So just, again, I just want to mop up as much as possible. I just want to make sure there's nothing else going on. Although this doesn't look sinister in any way, but it has been instances in the past where you clear something and there's something hidden underneath, like a hidden doorway. So I'm just going to stretch the ear open. I'm going to have a good look at that canal cholesteotoma. So this is more on the, again, it's more on the anterior canal wall. We call it, well, technically it's the anterior inferior, so it's kind of the southeast portion of the ear canal. But I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.